Well, you will see that there is some common theme that runs through these three cases. This 69-year-old woman without a significant past medical history had been well until 18 months prior when she began with various aches and pains, initially labeled as fibromyalgia, for which she took some non-steroidal anti-inflammatory drugs. 4 months ago, she developed lower extremity edema, and eventually she was discovered to have hypertension. And the laboratory studies revealed proteinuria, hematuria, hyperlipidemia, and a mildly elevated serum creatinine. The systolic blood pressure taken at home fluctuated between 150 and 170 systolic, up from a baseline of 120 or 130. And she was referred to nephrology. At the clinic, the review of system is negative, and she denied any other recurrent illnesses, rash, pain, joint pain, or recent use of non-steroidals. She was not on any other medication. Social history is negative for the use of tobacco, ethanol, and illicit drugs, and the physical exam is entirely negative except for blood pressure, 170 over 95, and she had 3+ lower extremity edema. BUN is 30, creatinine 1.5, up from a baseline of 1 4 months prior. Hemoglobin A1C is 5.8, normal complement levels. She has a positive ANA, a negative ANCA, and a negative hepatitis B and C serology. Serum albumin was 2.9 grams per deciliter, and the cryoglobulins were negative. The IgG is 631, which is on the low side. IgA was 237, which is normal or within the normal range. IgM 90, kappa 29, free lambda is 14 with a ratio of 1.88. And her urine showed 3+ blood, 3+ protein, and the sediment revealed 20 to 50 red blood cells per high power field, some white cells, and cellular cast. The urine protein to creatinine ratio was 5. And albumin to creatinine ratio was 3,831 milligram per gram. And the kidney biopsy was performed. So I'm going to show you the kidney biopsy, and you will answer eventually, hopefully, this question. I will show you 4 slides, and the question that I'm posing: crescentic, no glomerular abnormalities, membranous changes, membranoproliferative changes, or a collapsing glomerulopathy. So here we go with the 4 slides that I have chosen. This is obviously the low power. This is medium power that's showing you 2 glomeruli in the center and the rest of the cortex. Not the rest of the cortex, some of the cortex, a sample of the cortex. This is a higher power on an H&E that highlights the cells inside the glomeruli, the nuclei at least, to get an idea of what the pattern is. And this is the 4th, the PAS, that highlights the basement membranes of the basement of the glomerular capillary walls. Okay, now the question: what is the pattern of injury? Is it crescentic, no glomerular abnormalities, membranous, membranoproliferative, collapsing, GN? So now you get to work on the answer to this. Okay. 50 have answered, so let's see what the answer is. And most of you think the patient has a membranoproliferative pattern of injury, and I think those were right. Membranous is sometimes difficult to separate. The usually they have 2 lines of basement membrane. Sometimes it's difficult to see it. Sometimes it was too low a power. I can admit that. So let's see what we have next. So what mechanism is responsible for this pattern of injury. Is it an immune complex deposition, activation of classical pathway, no immunoglobulin deposits, paraprotein deposition and activation of classical activation, no immunoglobulin, and can't decide. So I'm going to show you 2 slides to go with this question that will come up again. So this is the IgG finding in one glomerulus, and this is the C3 and the C1q finding on this glomerulus. So, and now you get to answer. What do you think is behind this pattern of injury with the immunofluorescence findings that I showed you? Okay, so let's see what you have there. So the great majority of you think that the patient has immune complex deposition activation of the classical pathway. There was indeed C1q, okay? Very few of you thought that no immunoglobulin, you thought that was non-specific, and a few of you thought there were other mechanisms, paraprotein. Okay, so let's see what we have here. So this is kappa and lambda. And you can see that it can be confused very easily. There is no lambda, there's only kappa. And therefore, what looked like a bona fide immune complex is actually just the paraprotein that folds in an abnormal way, that aggregates in the glomerulus because of physicochemical characteristics or other characteristics, activates complement, because the activation of complement depends on the closer position of 2 IgG molecules. And in this case, the 2 come together for other reasons, not necessarily an antigen, but they aggregate and they form. And here you see the verification of that point, that it's actually only gamma 3 that is present in the glomeruli. The others are virtually negative or very little. So what needs to be done here is not to look necessarily for an immune complex disease, although it's always useful to do that. One has to look for a paraprotein. And here you see a very proliferative, very inflammatory lesion. These are all inflammatory cells here. And then you see a subepithelial deposit, but many subendothelial abnormalities. And in this case, the deposits are rather electron transparent. They are not very dense, but they have this like crumpled paper appearance. So this is where the immunoglobulin has folded in a particular way, formed an aggregate, and through that mechanism, the paraprotein has activated complement via the classical pathway. So here you see again, even in the subepithelial deposits that sometimes happen in these cases also, like a membranous pattern or a subepithelial aggregate of the paraprotein is there. And here you see the subendothelial aggregates with these very elaborate pattern substructures, we call them. Sometimes they are tubular substructures, as you see here. Sometimes they are aggregated as amorphous material. So this patient has an IgG3 kappa monoclonal immunoglobulin deposition disease that has resulted in the nodular and membranous proliferative pattern of injury. And it is a classic example where you really need to look for a lymphoproliferative disorder or a myeloma in cases like this. So the plasma cells were seen to encompass about 5% of the overall cellularity in the bone marrow. The immunoperoxidase stains showed that the CD138, which are the plasma cells, exhibit monotypic cytoplasmic reactivity for immunoglobulin kappa and lambda light chain. So they show basically polyclonal, so there is no clonality in the plasma cells. Normal trilineage hematopoiesis was noted, and on flow cytometry, no clonal population of plasma cells was identified. So the question is there something missing in this study? Yes, what is missing is that they did not look for clonality in the B cells. And this is a classic, I mentioned it to you before. You have to order this specially. The pathologist cannot decide to also look for B cells, even though they may suspect something, because the order says just plasma cell clonality, looks for plasma cell clonality, and therefore this needs to. Sometimes the PET scan is also useful because it shows some lymph node group that may harbor a relatively benign lymphoproliferative disorder. And here you can see eventually 8 months later, the patients had another study of the immunoelectrophoresis, and you can see a very faint band here of IgG and kappa. Very faint, and again, at the beginning it wasn't there. Remember that paraproteins are like any other chemical that you determine in the plasma. The level in the plasma will depend on the input and the output. If you don't have enough in, the level is too low to be detected by the relatively insensitive method that we call immunofixation. It is sensitive, but not as sensitive that you would detect any old immunoglobulin. So here you have a paraprotein that is barely detectable even after the kidney had already had the damage. So in this particular case, one of the many forms in which the kidney can be affected by paraproteins listed here is what people have called heavy and light chain deposition disease. This is not just the light chain that deposits in the form of amyloid or in the form of light chain deposition disease. This is not just the heavy chain, it's the entire immunoglobulin. And because it is the entire immunoglobulin, it is likely to potentially activate complement, either the alternative pathway, if it is an IgG2 or an IgG4, or the classical pathway in the case of an IgG1 and an IgG3. In this case, it's an IgG3 that was able to activate complement via the classical pathway, giving you an inflammatory glomerulitis. So monoclonal immunoglobulin deposition disease, non-amyloid, this is another way in which it has been described. You can have these immunoglobulin, as I mentioned, depositing only as light chains when they overproduced, only as heavy chain, which is very rare. And in my opinion, now this is a study from the Columbia group, in my opinion, this is a much higher frequency. The light and heavy chain deposition disease is, in my experience, much, much more frequent than light chain deposition disease. And here you have my experience at the Brigham a few years back. We had 38 cases of this condition where the entire immunoglobulin deposits versus light chain deposition disease, we only had 7. And if you compare to AL amyloid, what everybody knows, AL amyloid, we only had 53 cases. So it's almost as frequent, this disease with proliferative lesions, almost as frequent as AL amyloid, at least in my hands. So I think this is underdiagnosed and it is often confused with quote unquote idiopathic MPGN or some other mesangial-proliferative GN or what have you, okay? So remember the pattern of injury, membranoproliferation needs to be dissected. If it's immune complex diseases, infections, or autoimmune, if it is monoclonal, you have to be able to recognize it. So in the report that you get from your pathologist, if there is no mention of light chains, it means that it either wasn't done or it wasn't mentioned, and it is always worth for you to know that they should be mentioned at least, that they're equally present in a conventional immune complex, or there is only one of them present, and hopefully you can come to the bottom of these cases. Questions? Well, I guess there is no way in which there is no microphone. So let's go on to the second case. This is a 44-year-old African-American woman from Kenya with a history of HIV, and she is on several therapies, as you can see there. The CD4 count is 163, and she has an erosive seropositive rheumatoid arthritis. Previously, she was on methotrexate, now on prednisone and hydroxychloroquine. And she wants to become pregnant. She was admitted to an outside hospital for an acute kidney injury, quote unquote. Everything these days is acute kidney injury, thought to be lupus nephritis, complicated by a non-steroidal effect or toxicity of tenofovir. She was eventually transferred to our hospital for further management. This was a weekend, a complicated patient, so we got the patient there. She presented to the outside hospital on July 23 with chief complaint of intermittent chills, night sweats, and 5 to 8 pound weight loss over the last few weeks, and more recently nausea and vomiting, dyspnea, and she also developed persistent dry cough. She denied rashes and arthralgia. Her physical examination showed a body weight of 94.3 kilogram, temperature 36, blood pressure 109/44, and the rest of the exam was unremarkable except for bilateral rales on pulmonary examination. She was found to have severe pitting edema. Laboratory test revealed a sodium of 140, potassium 4.2, chloride 102, CO2 21, BUN 74, creatinine of 3.15 with an estimated GFR of 17 ml a minute. Calcium was 8.3, phosphorus 5.9. The glucose 126, total protein 5.1 gram per deciliter in the serum. Serum albumin was 2.3, white count 8,000, hemoglobin 7.3, hematocrit 21, platelet 17,000. The reticular count was 4.5 and the LDH was 92. The random urine protein was 407 milligram per deciliter, and the protein to creatinine ratio was 2.5 grams per gram. The urinalysis showed a specific gravity of 1026, pH of 5, 2 plus protein, 3 plus blood, red blood cells 182, and white cells 77. Other laboratory tests revealed a positive ANA, 1 in 640, homogeneous anti-double-stranded DNA 40, anti-cardiolipin antibodies IgM was 25, and a low C3 and C4. Hepatitis B serology antigen and hepatitis B antibodies were negative. She was treated with Solumedrol under the impression of a possible lupus nephritis, but the course was complicated by increasing azotemia, and she was started on CVHD. At the outside hospital, she had undergone a bone marrow biopsy for her thrombocytopenia. The bone marrow workup showed reactive changes, no evidence of malignancy, but the PCR showed positive for parvovirus. US, no hydronephrosis, and a kidney biopsy was performed after she received a platelet transfusion. So I'm going to show you 3 slides on the morphology, and I'm going to ask you eventually this question. And this is the first light microscopy slide. The low power, PAS on top, H&E in the middle, and the silver stain that stains basement membranes on the bottom. This is the second image with 2 glomeruli in the cortex. And this is the H&E of one of these glomeruli. And now you need to decide what this patient has in terms of the pattern of glomerular injury. So crescentic lesion, a membranoproliferative pattern, no glomerular abnormalities, membranous, or minimal glomerular abnormalities. Remember, the title of this session is Challenging Cases, okay? Okay, let's see what you think. Okay, membranoproliferative pattern is favored by most of you, and yes, I would probably agree to that. But then again, what does it tell you? I would argue very often not very much. So I'm going to show you 4 additional slides now. And then you need to answer, is it activation of complement via the alternative pathway, immune complex deposition or activation of classical, no immunoglobulin, anti-GBM, or thrombotic angiopathy? So here you go with the first one, albumin and IgG compared on the same slide, same exposure. Kappa and lambda compared, same exposures, same area of the slide, consecutive slides. C3 and C1q. And now you get to answer. What mechanism is responsible for the glomerulopathy? Activation of complement, alternative complement pathway, immune complexes with classical pathway, no immunoglobulin, anti-GBM disease, and thrombotic angiopathy. Okay, let's see what you think. Okay, that's why this is challenging. You see, this is why this is challenging. Well, I gave you, it was a tricky thing that I did because I didn't show you the electron microscopy, and I think that is often where the answer is. And what you see here is a completely destroyed capillary. There is basically no endothelial cover in many of these capillaries, or they are filled with cell debris, what we call interposition of cells, foamy macrophages, little platelets are present here. And this is what basically you have. Here you can see the endothelium is completely missing, and what is remnant are pieces of endothelial cell, red cells here, in what remains of the lumen, but basically the endothelial cell has been pulverized, has been destroyed completely. And this is what an acute endothelial injury looks like, with a pattern that is probably best described as thrombotic angiopathy. Now, there are no thrombi, there are no fibrin thrombi, because these diseases are characterized by platelet activation, platelet thrombi, platelet consumption rather than fibrinogen consumption. So these patients don't have a hypofibrinogenemia, they have low platelets because the platelets are being consumed by the rough, damaged endothelium. The endothelial cell is the target here for this particular disease. The parvovirus was completely negative. The parvovirus probably triggered the disease, the active disease. This is a control slide on a positive control also in the kidney. So parvovirus was not directly involved in the injury, but potentially indirectly involved, like so often these patients have an infectious trigger. The disease is uncovered by a trigger. The patient has, in addition, of course, tubular injury. There's some necrotic debris in the tubules from this severe injury. So this patient has an acute thrombotic and microangiopathy, if you want, predominantly, because mostly the glomeruli were involved, with widespread glomerular endothelial cell injury and swelling, what we call endothelial. If this patient had been pregnant in the third trimester with preeclampsia, this would have been a classic example of the kidney involvement in a pregnancy-related complication of the type of the acute, like we used to call it, acute kidney failure. So the patient, in addition, has acute tubular injury, of course, and there is no evidence. There wasn't a single immune deposit by fluorescence or by EM, even though the patient had this history of lupus or some kind of an autoimmune disease. So the acute thrombotic angiopathies come in so many flavors clinically, but basically from a pathophysiologic point of view, and this may be important for you to remember, what are the diseases that are associated with this type of injury. But basically, you need to analyze the various aspects that come to bear on this kind of endothelial injury. And in this patient, the functional test did not show any abnormality of the alternative complement pathway to make the diagnosis of atypical HUS, if you want. However, there was clearly a pathogenic abnormality of the C3. So this patient has a pathogenic genetic defect of C3 that most likely resulted after a triggering event, resulted in activation of complement via the alternative pathway, potentially with some other intercurrent processes that damage the endothelial cell, and she manifested this under these circumstances with a thrombotic angiopathy. And even though this is complicated, in my experience at least, very often these patients have a multifactorial kind of condition. On the one hand, you have a triggering event. And sometimes the trigger is the only thing that is abnormal in these patients. Classic example of that is when patients have an E. coli infection with the verocytotoxin-like infection of the gut, or a pulmonary infection with a verocytotoxin producing bacteria. Sometimes drugs can produce this anti-VEGF, for example, that is used for some cancers these days, can produce this gemcitabine I mentioned. And sometimes the only thing abnormal is the triggering event. Now, parvovirus in this particular patient, which was the only recognizable triggering event in addition to the autoimmune condition that she had, it's probably not known, parvovirus by itself, to cause this kind of thrombotic angiopathy. So these triggering events lead to endothelial damage of some sort that under normal circumstances is probably taken care of by our system. However, if the patient has some coagulation abnormality, be it genetic variants or autoantibodies or paraproteins, this gets exaggerated by failure of the endothelium to maintain a thromboresistant surface, and you have intravascular thrombi. These intravascular thrombi, driven in part by the triggering factor, but also conditioned by potential prothrombotic states, lead to, of course, mechanical damage, the hemolysis, if you want. This leads to complement activation. Each time you have injury of cells, there is complement activation. And this complement activation gets exacerbated by abnormalities of the alternative complement pathway, be it genetic variants or autoantibodies. In this patient, she had a C3 abnormality that is likely pathogenic. So this genetic variants, together with whatever triggering factor was there, and potentially other factors that were not studied, lead to this vicious circle, if you want, this positive feedback loop that leads to additional endothelial injury, more intravascular thrombi, more hemolysis and injury to the tissue, and more activation of complement that ends up with a catastrophic disease in the glomeruli. I must tell you that very often in medicine, we focus only on one disease, and we are happy to find one factor. But in this particular group of diseases, I think there is more than one factor that we need to take into account. And if we only recognize one of the potentially many factors, I think we are up for trouble, and that the patients will have recurrent disease later on with other triggers, with a pregnancy, with another infection, with a drug, or what have you. So in general, this is not easy and not cheap to analyze in patients. And what we need to do, we need to look at complement pathway on the one hand, and we need to look at the coagulation pathway, which are the conditioning factors. And there are a number of genetic abnormalities that belong to the alternative pathway, and there are a number of genetic abnormalities that belong into the coagulation pathway, if you want. Plasminogen, for example, is a cause when you have a genetic cause of atypical HUS, well recognized these days. Also the DGKE, diglycerol, I can't even spell it, that causes this. In addition to the genetic abnormalities, you have potentially autoantibodies. On the complement cascade, you have the anti-factor H, the C3 nephritic factor, the C5 nephritic factor, autoantibodies. On the coagulation pathway, you have anti-ADAM TS13 in case of TTP, for example. In between, I don't know where to put them, are antiphospholipid antibodies and the lupus anticoagulant. Hard to tell where they belong. They probably belong to more than one factor. And finally, you have another acquired factor that can interfere either with the coagulation cascade, with the complement cascade, or with the coagulation cascade. Those are the paraproteins that act not like the previous case in the glomerulus. They act in the fluid phase. These paraproteins act in the circulation by interfering with either the complement cascade or the coagulation cascade, contributing to this positive feedback loop that ends up with patients with these catastrophic thrombotic angiopathies. Okay, I'm sure you have questions. We will see. But there is, I believe there is another lecture on thrombotic angiopathies. I hope you can integrate this with this other morphological and pathophysiological approach to the thrombotic angiopathies. Okay, and then we have the third challenging case. This is a 52-year-old man, consults with his PCP for recent onset of headaches. His workup was notable for a creatinine 1.6 and a hemoglobin of 12.8. His SED rate was 24. He underwent additional workup, which included a serum protein electrophoresis. This study showed a monoclonal spike of 1.9 grams per deciliter with a total protein of 8.1 in the serum at that point. There was non-specific proteinuria of approximately 2 grams per day. Evaluation by the local institution revealed a concern for AL amyloid, given the renal dysfunction and the borderline increase in intraventricular septal thickness of his heart. So 4 months later, his BUN was 22 and the creatinine 1.8. His calcium was within normal limits. A bone marrow biopsy showed 5 to 6% plasma cells on a core biopsy. Flow cytometry showed diploid and haplodiploid cells with kappa light chain excess. By report, the patient also had a kidney biopsy, which failed to disclose the presence of amyloid, and the patient is seen for a second opinion. So the question to you eventually will be, what is the most likely diagnosis? No, the question right now is, what is the most likely diagnosis after having heard this story? And I'm sure I left out some critical clinical information. So you get to vote. Is this AL amyloid? Is it AA amyloid? Is it light chain deposition disease? Is it myeloma kidney with cast nephropathy? Or is it light chain tubulopathy? Okay, we'll wait for 50 of you to answer and then we will stop it. Okay, 51, bingo. Okay, so you can see that the majority of you favors light chain deposition disease and a few others, the other choices. So obviously, without a biopsy, it's kind of tough. Fortunately, we had a biopsy here, so it was suggested that maybe the biopsy, like when the patient is referred, they always want your local pathologist to also agree with what you have. Okay. What do you do next with all this that you have heard? Diagnose MGUS and follow patient every 6 months. Repeat the kidney biopsy. Review the kidney biopsy. Treat as multiple myeloma. Review the bone marrow biopsy. So now you get to choose this other clinical question. Okay, 50 of you answered. And thankfully, the majority of you thought that reviewing the kidney biopsy by a second pair of eyes is always a good idea. It's never excessive. It's not that we don't trust anybody. It is just that sometimes it needs another approach, another view, another aspect of this. So yes, indeed, you don't want to biopsy a patient again when the answer may be staring you or not so much into the eye. So here we have, on top is the, I can't even recognize this. The bottom is the PAS. You have a trichrome here, probably on top, and you have an H&E in the middle of this patient's biopsy. Here you have the light microscopy of a cortex with some proximal tubules and with 2 glomeruli. I'm confident you recognize them. This is the higher power on a PAS on the proximal tubules. And here is an H&E on those same or similar proximal tubules. Notice these are proximal tubules, the red ones, and these are the distal tubules. So And these are the paraffin section after antigen retrieval. And you can see here very prominent kappa, but not lambda, very few lambda. Obviously, lambda light chains are being produced normally and get excreted and metabolized by the proximal tubule. So you will always have some lambda light chain staining and kappa light chain staining in the proximal tubules. But this difference is clearly too much. This difference means that the kappa is preferentially aggregated or concentrated in the intracytoplasmic organelles, in this case, lysosomes. And here you see the classic pattern. This is a distal tubule, no lysosomes. Here you see the electron-dense lysosomes. Many of them have a very odd shape. They are not nice, round, like regular protein reabsorption granules. They are angled, they are crystalline looking, and indeed, the protein crystallizes, forms crystals inside the lysosomes. These are constipated lysosomes. They cannot digest the protein. The protein is folded in a particular way or crystallized so that the enzymes present in the lysosomes cannot get and digest them appropriately. And here you see the crystals forming inside. This is brush border of the proximal tubule. Here the mitochondria being eliminated, basically. The mitochondria cannot do their job for the reabsorption of the proximal tubule. And not surprisingly, these patients very often have variable forms of Fanconi syndrome. It's a kind of specific failure of the proximal tubule. And when the proximal tubule fails, you have dysfunction of what the normal proximal tubule does. So here you even have in the podocytes, you have sometimes these crystalline structures. And some of these patients can have substantial podocyte injury due to this accumulation inside the lysosomal structures, and they can have substantial proteinuria also, some of these patients. So this is not just tubular proteinuria. Sometimes these kind of diseases affect also the podocytes, and you can have a significant proteinuria. So this is the entity called light chain tubulopathy. Sometimes, initially, we called them crystal storing tubulopathy because it looks like a storing disease. In this case, associated with monoclonal kappa light chain proteinuria. So if you think that the only complication from a myeloma or a lymphoproliferative disorder is AL amyloid, and this is when the preconceived notion of what the patient should have gets in the way of making an objective diagnosis. Here, what was missing, the forest that was missing was the tubular pathology, which is very abnormal. Sometimes, as I mentioned to you, these are crystals forming inside the tubule. Sometimes they are fibrils. And sometimes the fibrils look very much like amyloid inside the lysosomes of the tubules. And sometimes they look like these elongated crystalline structures. So depending on the kappa light chain, you can have crystalline structures, you can have fibrous structures, but in any event, they are accumulating in the lysosomes of the proximal tubule in different shapes, displacing the mitochondria and interfering with the function of the proximal tubule. So light chain proximal tubulopathy are intracellular deposits of the light chains that cannot be digested for whatever reason. And this is from the Columbia group, the experience of them with this kind of disease. Notice not all patients have a monoclonal spike when the diagnosis is made in the kidney, but the great majority, of course, have detectable light chain. The free light chain assay is abnormal in the great majority of patients, of course. You detect an abnormality in the ratio. On the bone marrow biopsy in this particular work, 30 had plasma cell neoplasm, 1 has a CLL, 1 has a non-Hodgkin's lymphoma, and 5 had no evidence of malignancy at that time. The evidence was in the kidney. The kidney sometimes acts as the canary in the mine shaft in that it manifests the disease much earlier than any other parameter, either in the circulation or in the urine or in the bone marrow. So the clinical features, of course, all are surrounding the Fanconi syndrome, glycosuria alone or with other abnormalities of the proximal tubules. Renal insufficiency is often the case, and we don't know exactly how from the tubular injury you lead to renal insufficiency, what the mechanism is, or the low GFR. And 98% with some level of proteinuria, low level, but as I mentioned to you, sometimes the podocytes are involved as well. So here you have another manifestation of paraprotein, whether it comes from a plasma cell disorder or a lymphocyte disorder, needs to be evaluated these days because the therapy of the underlying disease is very much dependent on whether you are dealing with a B cell lymphoproliferative disorder or a plasma cell disorder, and therefore the bone marrow and the body needs to be examined for the presence of lymphoproliferative disorders.